Rebecca Reif. Becca joined the APBD Research Foundation team this past summer. After earning her Master's of Science in Genetic Counseling from Penn, Becca is committed to driving progress in rare disease research and patient advocacy to support the development of new initiatives aimed at empowering patients, fostering collaborations, and accelerating drug development. Becca, take it away.
Thank you so much, Calliope, and thank you so much to Dr. Abreu and our three incredible rising researchers. We are so thankful to have you on our team and really looking forward to see all of the amazing work that you'll do in your career. Now, I'm very excited to start to wrap up the day with this panel, which I think will leave us with a sense of hope for what's to come. We're going to be talking about what to look forward to in the upcoming research and publications. So it's my honor to introduce our four panelists. We have Dr. Rebecca Koch joining us, a postdoctoral associate in the Department of Pediatrics at Duke University Medical Center, Dr. Felix Nitschke, an assistant professor in the Departments of Pediatrics and Biochemistry at UT Southwestern Medical Center. He was a moderator for many of our sessions, so many of you will recognize him. Muriel Singer-Burke, a senior clinical genomic variant curator at the Broad Institute of MIT and Harvard, as well as Dr. Andrew Duguay, a neuro-ophthalmologist at NYU Langone Health. We're very excited, so let's dive in.
Perfect. Well, one, I just have to say, this is the first time there's ever been another Rebecca, or Becca, I should say even more clearly. And so I am excited. Once I come back from maternity leave, I'll be staying on as faculty with this group. So you're stuck with me, but Becca, we're going to have to figure out our what we go by. And then I'm excited for this presentation specifically because I feel like it's just a highlight reel of the exciting work that's going on with our team. So I'll dive right in. I'm just going to give a bunch of updates from our natural history study, both recently published and coming out soon. I'm going to go fast just for time, but I hope this just gives you an overview of the exciting projects that we're working on. I'm going to skim past this because I know Dr. Kishani also mentioned this yesterday in her presentation, but just want to emphasize natural history studies, why they're important. I've heard this word come up about 1 million times in this conference for good reason. So I don't think I need to clarify, but again, we're finding out so much from these natural history studies about what unmet needs there are and also about helping us understand disease. And supporting the development of treatments and therapies, not just at our own group, but we're hoping to share this information with the group at large. That way, others who are doing work can correlate their results. So this is our natural history study. It's on clinicaltrials.gov. I put a screenshot here. It has a long title because we're trying to capture the attention of everybody. So it's called the GBE deficiency or GSD4 and APBD natural history study. And that's just, again, for keywords. So that way, when people receive this diagnosis, sometimes it's called GSD4, sometimes it's called APBD, sometimes just they're told they have deficient glycogen branching enzyme activity. So trying to capture everybody there. I will say I put my email there. I am on maternity leave until next month, so I might be slower to respond, but I promise I will respond to you. And as Dr. Kishani said yesterday, this is an international study. It's housed at Duke, but it includes patients from all over the world. It's done completely remotely, and I'll talk about that in a second of we're trying to take the burden off of you as much as possible of getting this information. It also includes decedents. So if you have a family member or someone who is deceased from this disease, but you would like to include their information, you can reach out to me and we can go over what the parameters are there. And we also include autopsies, as well as we have a biorepository for tissue, blood, and urine as well. So I can go over all those details at a later time when we have more time to chat. So I'll take any chance to brag on my team. So just for a second, it takes a village. I am speaking on their behalf, but this really is not just the clinical research side, but also our bench team, who I think is always working behind the scenes and doesn't get the credit they always deserve sometimes. So we do take a translational approach. So Dr. Kishnani, who wasn't able to be here today, but she is the principal investigator. I'm a co-investigator on the study, and our wonderful clinical research coordinator, Nisha, who you probably speak with a lot more now if you're enrolled. And then we have a whole host of team members that I list below, including our wonderful pathologists who collaborate with us, as well as several medical students and postdocs, and also our lab, of course. And I do want to say all of this is PI initiated, meaning there's no direct funding source for this work. So I just wanted to highlight that because that's why I didn't list the funding source. And this is a really simple schematic, but sometimes simple is better, I suppose. So our goal with this natural history study is not just to have this wealth of data. Of course, for the FDA and any clinical trials, they're going to need natural history data, not necessarily published, though I have heard they do prefer published data, peer-reviewed published data. So that is ultimately our goal, is to publish this data. But of course, we still have a ton of data that's not published, just because we need the hands to actually publish it. And our goal with these papers is to improve clinical care and patient management, just like you're seeing today and yesterday, support the development of treatments, and also provide that natural history for the clinical trials. I will say again, because this is PI initiated, there's no industry sponsor. There's pros and cons to that. Pro is that we have all of the data. Con is, of course, we need the people and the funding to keep being able to get this data out and publish and everything. So we're a smaller team, but we're an effective team, I like to think. And so we're trying our hardest to get this out in a timely manner. And so I'll skip ahead. Again, I know you saw this yesterday with Dr. Kishnani's presentation. So I'll just highlight again that GSD4 is known to have several subtypes. And as she mentioned, we did do a study a few years ago that found that the published cases, the pediatric onsets, not APBD, but the pediatric onset GSD4 cases did not fully correspond with the established subtypes in the majority of cases. So this was why we looked into really evaluating the subtype system further and trying to help patients who really didn't fit in these categories, but also that they felt like they were boxed in and that no one would really evaluate, let's say, the heart if they were in a hepatic subtype. So that was the rationale for this most recently published paper that just came out, I think, literally a month ago to the date. And so this was a natural history study of hepatic GSD4. So patients that had liver disease at some point in their life. There were several conclusions from this paper. A highlight of it is that liver biopsy severity is not predictive of liver disease prognosis in GSD4. So not necessarily for the patients with APBD or the caregivers on this call, but for the individuals that are affected by liver disease in GSD4. Oftentimes a liver biopsy is part of their diagnostic process. And what we found is that the level of fibrosis and cirrhosis was pretty much the same amongst all individuals. And you couldn't tell who was going to rapidly progress versus whose liver disease was going to stabilize. So that isn't necessarily helpful in terms of prognostication, but it is helpful to know that you seeing this on a biopsy is not, this set course. So it's really helping us make better recommendations for who would receive a liver transplant and who should be followed closely. We do recommend changing the nomenclature for hepatic GSD4 subtypes, and I'll talk about that in just a moment. And we also do document the link between hepatic GSD4 and APBD. There were 2 papers before this that did talk about patients that were known to either have a family history or personal history of liver disease, and then go on to develop APBD. So this is, again, further providing evidence of that, and also publishing the liver tissue that was diagnosis of hepatic GSD4 in childhood, and then later developed APBD. So we hope this is helpful there. And I mentioned this yesterday in the Q&A, but also we do list out the GBE1 genotypes of individuals who are known to be at risk for developing both. So again, just more from a counseling perspective and planning perspective for those children. This is a very busy swimmer's plot that shows the natural history of liver disease in GSD4. And there's so many icons on here. I think this is more helpful for a pediatric population conference, but what I wanted to highlight is these gray areas are all lack of data. So what I find really impressive here, not in a good way necessarily, but that, a lot of these patients are lost to follow-up because they receive a certain diagnosis, or they're told, okay, you have non-progressive GSD4 in quotes, and they think that their disease is cured, and then they come back with disease later on. So really just highlighting where we could improve in our clinical monitoring of these patients. This is the recommended nomenclature change. It's just essentially representing patients and addressing patients that weren't really fitting into this classic progressive hepatic subtype or the non-progressive hepatic subtype. The word non-progressive inherently implies that the disease is just not progressing, which Dr. Kishnani mentioned yesterday is not the case in many individuals. And there's extra hepatic involvement. So involvement of tissue systems outside of just the liver that often gets missed because you just hear of this non-progressive hepatic subtype thinking that the disease is not affecting any other tissues. So really just trying to bring light and represent a bunch of patients that previously were not captured in our subtype system. This slide might take a second to load because it's a large picture, but I'll let it figure itself out. So I'll talk while it's waiting. So we also looked at our mouse model that many of you guys have all talked about today and yesterday, and really just dove into the liver specifically and how the liver is involved in this disease in the mouse specifically, because we know the mouse is almost like a hybrid model of GSD4 and APBD. It does have involvement outside of the central nervous system and other tissues that are known to be involved in APBD. So as we think about therapies, and I think just basing off of even the group today of how people are mentioning, you know, a therapy for one either phenotype of GSD4, including APBD, or another disease in general, could impact others. Knowing how this model can be used for other tissue systems is really helpful. So we did characterize the natural history of liver disease specifically in this model at various age points to help those who are investigating treatments know how either the liver would affect their treatment, or also if they're trying to, to treat the liver disease, that this model could be used. So switching gears from the liver, now we're talking about neuromuscular GSD4. We're doing the same model of talking about this natural history and the variability that we're observing and applying it to the neuromuscular GSD4 community. And so this has been a hugely neglected community in terms of representation in the literature. Most people talk about the lethal form, and then of course APBD. But there is not a lot of understanding in the middle. And so that is what this poster that was presented at the SIMD conference a few months ago by my colleague really highlights. And so we're hoping to publish that later this year. And I would be remiss to not mention our APBD paper. And so we did publish a case series that was in a collaboration with Brazil. Sorry, I know I'm over time, I'll finish up. In Brazil, on 4 cases in Brazil and 3 cases in the US. This had a host of data, but again, was talking about the evaluation of patients from a broader demographic. We also did use patient-reported outcome surveys for guiding management, and we used validated ones that have already been published. I think there's a lot that we could do with the recent surveys that have come out that are more APBD specific. So I will close, sorry. This is our natural history study information. I think I just wanted to highlight, we have only 28 participants with APBD. If we want to move this forward, I think I would welcome your participation. So please reach out to me. We're planning to publish autopsy findings and of course the natural history of neuromuscular GSD4 in the next few months. And I'll just leave at my acknowledgements. Thank you, and thank you to the participants and their families.
Thank you so much, Dr. Koch. We really appreciate that and would love to dive into some of the implications from that work in the liver at the end during our Q&A. So now we can hand it back over to Calliope, who will pull up the slides, I believe, for Dr. Nitschke.
Thanks for the kind introduction, and also thanks for the opportunity to talk here at the APBD conference. The title of my talk is the title of the paper that we currently have in review. This paper links a novel metabolite, malto-oligoglucans, and overactive glycogen synthase to glycogen insolubility and neurodegenerative diseases such as APBD and Lafora disease. With time being limited, I will focus in this talk on the discovery of the malto-oligoglucans. Glycogen is a central metabolite used to store energy in form of large glucose polymers. It is important to note that water solubility is a prerequisite of functional glycogen. In both amylopectinoses, APBD, and Lafora disease, insoluble glycogen forms and aggregates into so-called polyglucosan bodies. In the brain, these lead to progressive neuroinflammation and neurodegeneration, in some cases to epilepsy, and always to reduced lifespan. In my lab, we're studying several amylopectinosis mouse models that accumulate insoluble glycogen for different genetic reasons. We are trying to understand how insoluble glycogen is formed and how it leads to disease. Another goal, of course, is to develop novel treatment approaches and identify biomarkers. At this point, I think we all know about the clinical signs of APBD, so I'm just going to mention that for our studies, we're using Dr. Ackmann's APBD mouse model that carries the Y329S mutation in the glycogen branching enzyme. The other disease we've been studying is Lafora disease, which is classified as a progressive neurodegenerative childhood onset myoclonic epilepsy, where patients and the mouse models accumulate polyglucosan bodies. Defects in either of the two proteins, laforin or myelin, cause Lafora disease. This means studies are involving two mouse models, one for each disease gene. As you can see here, the skeletal muscle of all of these mouse models contains substantial amounts of polyglucosan bodies. The pink signal is periodic acid shift stain after treatment with amylase. It indicates the presence of degradation-resistant glycogen aggregates. As the majority of glycogen in the human and the mouse body is stored in skeletal muscle, we had previously used skeletal muscle glycogen as a model to better understand the principles underlying the formation of insoluble glycogen. The first step toward understanding polyglucosan formation is to characterize soluble and insoluble glycogen in these mutants. We therefore established a method that allowed us to quantitatively separate soluble and insoluble glycogen from the total glycogen in muscle tissue. Using this separation method, we found the following in the mouse muscle. As expected and as previously described, the total glycogen content is elevated in all three mutants. Interestingly, the amount of soluble glycogen is unchanged from wild type, irrespective of the deficiency. The accumulation we see in the total glycogen is exclusively due to an accumulation of insoluble glycogen on top of the normal amount of soluble glycogen. The respective wild-type animals do not accumulate insoluble glycogen. Now, as I said, all this was previously done in muscle, but since APBD and Lafora disease largely affect the brain, of course, we wanted to investigate this in the brain. There was just one problem. It had been shown that brain glycogen is very volatile under hypoxic and hypoglycemic conditions. Unfortunately, these are the conditions that occur exactly between the sacrificing of a mouse and the freezing of its brain tissue. In order to study soluble and insoluble glycogen in the brain properly, we obtained a microwave fixation system that allowed us to stop all enzymatic activity in the brain within 1 second. At first, we tested the fixation system and compared wild-type brains fixed by freezing in liquid nitrogen to those fixed by the microwave. Indeed, this ultra-fast microwave fixation preserves 40% of glycogen that is otherwise lost when the brain is frozen after dissection. We could also show that after microwave fixation, exposure to room temperature doesn't affect the brain glycogen content anymore. This proves that enzymatic activity is indeed halted completely by microwave fixation. Before I show you the results we obtained using microwave fixation, let's have a look at what we saw when metabolism was stopped by freezing of the brains. Essentially, we see exactly the same as what we saw in the muscle. Soluble glycogen is wild-type-like, and insoluble glycogen accumulated in addition to soluble glycogen. Now, the big surprise happened when we looked at the microwave brains. Here we saw a substantial increase in soluble glucan content in all three models. The fact that we needed the microwave to see the elevated glucan indicated that it is a form of glucan that is metabolized very fast, meaning in the first 30 seconds after stopping blood circulation. So far, we had detected the elevated glucans in aged mice. In the Lafora disease models, we also checked if they are already present at young age, and as you can see, they are not. Therefore, we concluded that the metabolically volatile glucans accumulate with disease progression. From other experimental observations that I don't have enough time to go into right now, we had the notion that the excess soluble glucan material is much smaller in molecule size than regular macromolecular glycogen. We tested that by a simple filtration experiment where we analyzed how much of the entire soluble glucan can pass a 30 kD, 30 kilodalton filter. For instance, here in one of the Lafora disease mouse models, you see the values before filtration. And now after filtration. In the wild types, almost all glucan material is larger than 30 kilodalton. In the mutant, however, most of the excess glucan material that we found to be metabolically volatile disappears through the filter, which means it's smaller than 30 kD. We started calling the glucan malto-oligoglucan, or MOG, because due to its much smaller size, MOG is distinct from macromolecular glycogen. If we subtract the MOG, the macromolecular glycogen is almost the same in mutant and wild type. We see very similar results in the other Lafora disease model, and in the APBD model, it appears that actually most of the soluble glucan material is MOG, and that macromolecular brain glycogen is decreased. But that is a story for another day. MOGs could be a powerful option as a biomarker for polyglucosan body diseases, including APBD. In our Lafora disease mouse model, the MOG content of individual mutant mice correlates well with the expression of neuroinflammatory marker genes. In addition, soluble MOGs, as opposed to insoluble glycogen, are theoretically detectable by a novel MRI technique called glyco-NOE. We have heard about this promising, safe, and non-invasive imaging technique from Dr. Yadav yesterday. Overall, I believe the demonstration of MOGs in APBD and LD, Lafora disease, present two main opportunities for the APBD community. First, we can use the APBD mouse model to further characterize the MOG and its correlation to neuroinflammation and MRI signals. And second, we can include glyco-NOE and MRI scans in APBD patients to the systematic biomarker search, and that will help us to evaluate how the MOG signals correlate to other body fluid markers and to disease progression. With that, I'm going to end my talk, and of course, this project greatly benefited from collaborations and support within and outside of UT Southwestern. So my gratitude goes out to all these people and of course to you for your attention. I'm happy to take any questions. Thanks.
Thank you so much, Dr. Nitschke. That was really interesting, especially coming off of a day discussing biomarkers, talking about another potential one. So we really appreciate your work on that. And again, anyone with any questions, please feel free to throw them into the Q&A. We'll start collecting them for the Q&A at the end. And now we'll hand it off to Moriel Singer-Burke, who will tell us a little bit more about how we are estimating the prevalence of APBD and GBE1 related disorders with population databases. Thank you so much, Moriel.
All right, well, thank you again for the introduction. Today, like Rebecca introduced, I'm going to be presenting on how many of us are there using genetic prevalence to estimate the number of individuals with GBE1 related disorders. I do want to highlight that I'm mostly going to be referring to all GBE1 related disorders and not hyper-focusing on APBD or GSD4, as that is usually how we approach this prevalence work. But I'll talk a little bit about what we were able to return to the APBD Foundation through the CZI's Rares 1 initiative in the Cycle 1. So really all of this work we often refer to as putting the pieces together, and that's because none of what we do to create these estimates is actually proprietary to us or our team. We're using a bunch of open resources as well as literature that's been provided by researchers to put all of this information together to get these results. So it's something that really anyone can do. And then I do want to quickly introduce what I mean by genetic prevalence, as some of you might not have heard of this before. This is what we define as the estimated proportion of a population that has a causal genotype for a genetic disorder. In particular, we're talking about autosomal recessive disorders. And what this really means is we're trying to come up with an estimate of how many people may have inherited 2 different copies of the GBE1 gene with a variation that is known to cause disease. And why this is important is many reasons, one of which we usually report prevalence more on kind of like an incidence, which is based on clinical cases and reports that come through the clinical side. But when we're talking about rare disease, that can be really hard to get an accurate estimate of how many people in the world there actually are with different limitations. So this is a really incredibly useful tool to understand how many people there are for researchers, for advocacy groups, and we've seen it more and more come up in approaching pharma and biotech in order to come up with treatments. They often would like to know how many roughly people would require the treatment. And how we start getting all of this information together, which I often think of as our bread and butter, is kind of coming up with this full list of variation that is implicated in the disease that we're looking into, in this case, GBE1 related disorders. And we're pulling from all of these different resources. Often many of the variations we're pulling into our list are coming from ClinVar, as well as some disease-specific databases when we're collaborating with different organizations, and other of these resources here. What we use to actually come up with these results is from the NOMAD database, which is a population database that has allele frequencies from a supposed control or unaffected population. So after we are able to pull a list of variation, all that have implications in GBE1 related disorders from these different places, we do have to filter that down to what actually exists in the NOMAD database. That's because we're taking allele frequencies from there. So anything that is not found in that database actually doesn't add anything. It's an allele frequency of 0. So it's not adding anything to the estimates that we come up with. I am going to skip a little bit through this just because of time today, but I do have these in my slides. So if anyone wants to access them later, please go back and look into more of the process of curation, the slides I'm passing through. But once we are able to come up with this list of variation, we do pull all of those allele frequencies from NOMAD, as well as a global level, as well as in a population specific level. And when we're talking about the global estimates, we're only able to calculate those based on what's available in NOMAD, and NOMAD is not representative of the world's population. So just note that when I'm talking about global estimates, it's just based on what we have access to in this data set, which is growing in diversity, but is not currently at the level of what we would expect for the world's population. We're also able to look at these estimates for carrier frequency and prevalence in different subpopulations. And this is all defined from genetically defined populations, not self-reported. So that's also something we just like to note before we look at the results. And all of this is just to say that we put all this information that we're gathering into a pretty simple algebraic equation. This is the Hardy-Weinberg equation, which is a mathematical equation used to estimate the variation within a genetic disorder that's kept at equilibrium. And what's kind of convenient is for rare disease, we're able to actually make this even more simple because this value of P in this equation, it can be assumed to be 1. And so from there, the Q value that we're entering is actually the aggregation or the sum of all of those allele frequencies from the variation we pulled into the NOMAD database. And we use that value then to help us define the carrier frequency and the disease frequency by either doubling it or squaring it. And this is finally getting to the results here. When we finished, or kind of finished, we're continuing this collaboration, which is really exciting for our team. But when we first returned the results to the APBD Foundation, this is the results that we presented to them. This is accessible from a tool that we recently released called Genie. You can access it with the QR code at the bottom of this screen, as well as the link that's posted there. And this just takes all of that math and makes it really simple for everyone by putting it into this kind of format. So we have at the top here the global and population specific carrier frequencies that are estimated, again, for all GBE1 related disorders. This is not parsed by APBD or GSD4. And then we have the graphical kind of visual component on the right-hand side, which kind of helps get a sense of the differentiation between these different population groups. And then if you scroll lower down on the screen, you'll see this genetic prevalence, which I've just screenshotted here, which estimates, at least for GBE1 related disorders, a global carrier frequency of 1 in 280 approximately, and a global genetic prevalence of 1 in 320,000. If you do look at this right-hand side of the screen and see this more visual component, you'll see that a lot of the enrichment in this carrier frequency and genetic prevalence is due to the Ashkenazi Jewish population, which is actually really good to see, since we are well aware that many cases of APBD have been seen in those with the Ashkenazi Jewish background. When we did report this to the APBD Foundation initially, because we had taken such a deep dive into the phenotypes in each single variant that's implicated in disease, we were able to, in some ways, parse this by disease. And so I'm just showing the same graph here that was on that Gini slide from the left of the conservative carrier frequency. But now we've tried to parse in some ways how these are different based on the disease. So you can see in this case, it's pretty obvious that that higher carrier frequency in the Ashkenazi Jewish population is due to variation known to be seen in cases of APBD versus the GSD4. And what we don't love to do, but we often return back to all the groups we work with on genetic prevalence, is taking this genetic prevalence and multiplying it by the world population to just get a baseline estimate of how many people we think there are potentially walking around with GBE1 related disorders. So that's the numbers that we've originally returned to the group here. Around 26,000 is our conservative estimate of individuals with, again, all related GBE1 related disease. But big caveat here is, again, NOMAD is not representative of the entire world's population. And since that's where we get these numbers from, this is not going to be a perfectly accurate representation of how many people there could be. And then this is just something new I really wanted to have time to show. So in the last minute, I did take all of the variants that we have in GBE1 that we again have an indication that are involved with GBE1 related disorders, and popped it into Gini for a new version of NOMAD that was just released this year. So this just shows, and the difference between the NOMAD is just a lot more individuals. I think we went from around 150,000 individuals to close to 800,000 individuals. So we're just more accurately able to look at frequency with the growth in the data set. So here you can see that the global carrier frequency and prevalence actually hasn't changed too much, although it has gone down slightly with these new numbers. And then just because of time, I'm going to skip through my limitations. I think I've mentioned most of them, and mention that this is work that the APBD group is presenting at conferences and has been this summer and into the fall, and then is part of a publication that is in progress right now. So with that, I just want to thank you for your time, and happy to answer questions when we're ready for that.
Thank you so much, Moriel. This is really interesting work for our community, and looking forward to discussing it a little bit more in the Q&A, just to see if there are any strategies that we can consider implementing based off of this new information. So again, thank you so much. And it's my pleasure to introduce Dr. Andrew Duguay to show us some of their new work coming out of NYU on ophthalmologic presentations of APBD, which is something that we haven't really discussed in our community before. So really looking forward to hearing a little bit more about this. Thank you so much.
So thank you for the opportunity to present today. And I'd also particularly like to thank Dr. Abreu as well as the conference planning committee for the invitation. And so I'm really excited to share our research on the neuro-ophthalmic manifestations of adult polyglucosan body disease. I have no relevant financial disclosures. And so first, I would just like to introduce you all to the field of neuro-ophthalmology. So nearly half of the brain is dedicated to visual system related functions. And so neuro-ophthalmologists diagnose and treat conditions affecting the visual system. And so we divide the visual system into two major categories, the afferent visual system and the efferent visual system. So the afferent visual system, it consists of structures that are involved in seeing, such as the optic nerve and the visual cortex, the occipital lobe, for example. And the efferent visual system consists of structures that are involved in eye movements, such as the third, fourth, and sixth cranial nerves, and other pathways in the brain, brainstem, and cerebellum. So for example, this would be allow us to fix our gaze on an object or make rapid moves of our eyes between different targets of interest or smoothly track an object. And so dysfunction of the afferent visual system can lead to impairment of visual acuity, our visual fields, our color vision, and complex processing of visual information. Whereas dysfunction of the efferent visual system can lead to double vision, nystagmus, which is an involuntary rhythmic movement of the eyes, and eyelid ptosis, or drooping of the eyelids. And so I think we all are familiar at this point with adult polyglucosan body disease. That's from the glycogen branching enzyme deficiency leading to polyglucosan accumulation. And the chief features are here. And so our research focused on the identification of the neuro-ophthalmic manifestations of APBD through the experience of 3 patients, as well as a review of these manifestations in the literature. And so we mainly conducted our literature review through PubMed. And we found 26 studies of APBD in the literature with neuro-ophthalmic manifestations. And so we included these in our analysis. And we found that the major manifestations were optic neuropathy or damage to the optic nerves, eye movement abnormalities, as well as disorders of higher cortical visual function, so issues with visual processing. And so more specifically, polyglucosan bodies appear to accumulate in the afferent visual pathways, and this leads to degeneration of the optic nerves in some individuals with APBD. There have been prior studies that have shown pathologic evidence of atrophy of the optic chiasm and optic nerve, as well as polyglucosan body accumulation in the optic tracts and the occipital lobes. And so in our case series, we found that the presentation of optic neuropathy was mild, painless vision loss of both eyes with a gradual onset and progress over a period of years. There was associated decreased color vision, pallor of the optic discs, and thinning of the retinal nerve fiber layer on OCT testing, or optical coherence tomography testing. And in the literature, we found that optic neuropathy was noted in people who were in their 6th or 7th decade with APBD. So here's an example of an OCT from our series where you could see that this is measuring the optic nerve thickness. And the normal value of the average optic nerve thickness is supposed to be somewhere between 90 and 100 microns of thickness. And here you can see that the thickness is in the mid-60s here for each eye. So there's a significant amount of thinning. And that this also segments the optic nerve into different areas here, the temporal part of the optic nerve, and the superior nasal inferior parts. And we see that there's a preferential thinning of mainly the temporal and a little bit of the inferior optic nerves in both eyes, and it's a fairly symmetric pattern. This is also an example of 2 visual fields from 2 individuals. And we can see that there's quite a difference in the visual field appearance. So dark areas on a visual field test indicate areas where someone cannot really see. And so you can see that in this first set of visual fields for the left and right eyes, there's a considerable amount of superior visual field loss and central visual field loss primarily, whereas in the other set of visual fields, there's not that much visual field loss, pretty non-specific defects. So there is a spectrum in terms of the severity of visual field loss with the optic neuropathy. And so, as I mentioned earlier, higher cortical visual function can also be affected by polyglucosan accumulation in the visual association areas. And so the visual association areas are areas where the visual cortex is interacting with other parts of the brain, such as the temporal lobe and parietal lobe. And so that helps us with functions such as understanding where objects are located in space, recognizing faces, recognizing colors, things like that. And so these functions would be impaired potentially by polyglucosan accumulation. And on MRI imaging in our literature review, we found that about 54% of individuals with APBD had white matter lesions, mainly in the occipital lobes, or where the primary area of our vision is located in the brain. And So as I mentioned also, this more specific higher cortical visual functioning issues would include issues with visual attention, visual memory, perception, integration. So identifying the part of something versus the whole of something, individual trees in a forest, for example, and constructional apraxia as well. And so the efferent visual pathway, we found that polyglucoside bodies also accumulate in these other areas, the brainstem, cerebellum, and subcortical regions. And the MRI will also demonstrate white matter lesions in the brainstem and atrophy of the cerebellum and medulla, where these efferent pathways are mainly running. And our review showed that the most common efferent manifestations were saccadic pursuits. So instead of being able to track things smoothly, people who are affected would have kind of choppy movements or quick eye movements when trying to track an object. And also slowed saccades. Instead of having a fast eye movement to capture a target of interest, it would be a relatively slow movement. Also, nystagmus was observed. Other rarer features that had been seen were fourth nerve palsies, which would result in a symptom of double vision, convergence insufficiency, which is an inability to really move the eyes inward appropriately when looking at a near target, ophthalmoplegia, or basically paralysis of eye muscles, and eyelid ptosis, or drooping of the eyelids. So here's an example of an MRI showing that there is atrophy of the medulla here. You can see this is part of the brainstem, the medulla, lower part of the brainstem, and it's quite small relative to what we should normally see. So in conclusion, there is a wide variety of neuro-ophthalmic manifestations that can be seen in adult polyglucoside body disease. And as a result, we really recommend that neuro-ophthalmic evaluation should be performed for individuals with APBD in order to determine the range and severity of these afferent and efferent defects, and also to potentially optimize visual outcomes. Thank you.
Great. Thank you so much, Dr. Duguay. And I think we all have a ton of questions for all of you, but I think it might make the most sense to just dive straight in to questions about your presentation, just because we all just heard from you. Really interesting to hear that over half of our patients have white matter lesions in the occipital lobe, for sure. And you mentioned that literature review revealed optic neuropathy and saccadic pursuit as frequent manifestations for our APBD patients. Would you call these manifestations clinical pearls specific to APBD, or said in another way, with a cohort of only 3 patients so far, were there any interesting findings shared amongst the 3 of them that potentially we should look out for in the future in other APBD patients, or were they quite variable?
Well, I think so. It's a little difficult in this particular sense, I think, to draw kind of great generalizations here from the small number of cases that we're looking at here. But in our particular case series, all 3 of the individuals were related. And so that also could perhaps influence why they did have fairly similar manifestations as well in terms of the optic neuropathy that they had. And also the efferent manifestations were fairly similar between them. So I can't really draw a wide sweeping conclusion here, but these are some of the features that can be seen in optic neuropathy, as well as in combination with efferent manifestations, can be seen in a wide variety of other conditions. So it definitely we have to consider the whole clinical picture. The other systemic manifestations could point towards APBD if the diagnosis is not established. So it's definitely, I think, seeing the neuro-ophthalmologist is potentially helpful early on, if the condition hadn't been diagnosed previously, but probably the most benefit would be derived after they've been diagnosed from seeing a neuro-ophthalmologist.
Well, thank you so much for putting that into context for us. That's really helpful information, and really interested to see over the next few years if we see more reports in the literature. But thank you to you and your team for bringing this to the forefront in the literature. It's very important for our patients, so we really appreciate it. And staying on track with, manifestations in our patients. Dr. Koch, there had been an attendee with a question during your presentation when you were discussing the link between hepatic forms of glycogen storage disease 4 and APBD, and just discussing that findings from liver tissue collected from one known individual who was diagnosed with GSD4 in childhood and later developed APBD. Would you be able to speak to what the implications of that may be for our APBD patients at all?
Yes, and I apologize. I feel like I did a fast track. I just threw a lot of studies at you and hoped you caught up. But for the liver disease specifically, so for APBD, I want to be clear that individuals that have either the two Y329S, Y329S variants, or the Y329S with the intronic variant, we have not seen liver disease commonly in those individuals. So I don't want you to hear my presentation and think you have to go get your liver checked out immediately. In our clinical practice guidelines, we do state that as well, and you can give that to your clinician and they can review it as well. But for liver disease, we would recommend you get your average ALT that you should be getting annually anyway on your lab work. That would help capture if you do have any underlying liver disease. To really throw a wrench in this and make it really confusing is the autopsy that I mentioned where the individual had known liver disease, was cirrhotic on his biopsy in childhood, and then we had his liver at autopsy. There was not a lot of polyglucosan. The cirrhosis was still definitely present, though that individual did not have elevated ALT levels. They did not have any overt liver disease symptoms or signs. So to make it a little bit more confusing or just leave you with a question mark, we're still really investigating that. And that's why we really dove into the mouse model to see what learnings we can glean from it. But I don't want you to leave here thinking that liver disease is common in APBD, though I do want to be clear there are individuals that have different genetic variants and that for whatever reason, we're still trying to understand, they could have more of an underlying risk. And in general, because GBE is deficient still throughout the whole body, including the liver, even in individuals of Ashkenazi Jewish background, we still don't recommend, not getting checked with the ALT levels, drinking heavy sets of alcohol, or anything that could otherwise damage the liver because there is still that underlying disease risk.
Great. Thank you so much, Dr. Koch. I also just want to quickly highlight before we have to transition that we do have some specific questions for you, Dr. Duguay, in the chat if you're able to access that. If not, I can put you in contact after this event. I believe we do have to move on to our closing remarks. I have a ton of questions still for Dr. Nitschke and Moriel. I might have to chase you down for a post-conference interview or something like that to address these questions. But thank you so much to the four of you for all of the illuminating information. We're really looking forward to seeing this in the literature. We'll make sure to share it and make sure that we get it out to the world. Thank you all so much again. It's been a pleasure.